Hello and welcome to the Alabama Public Health Training Network. We're so glad you could join us today for this program, Successful Strategies for Integration of Immunization and Emergency Preparedness Programs in Planning and Practice. Our objectives today are to highlight ways to strengthen collaborations between emergency preparedness and immunization programs. We'll describe ways to overcome budget-related challenges during crisis situations. We'll discuss challenges and lessons learned from the 2009 H1N1 response. We'll provide examples on how communication challenges were overcome during the H1N1 response. We'll discuss resource sharing and allocation between programs during disaster response, and we'll describe the impact of organizational structure on each program's ability to collaborate. So certainly a lot that we're going to discuss here today. As a reminder, if you'd like to be a part of our discussion throughout the program, you will see our 800 number and our email address up on the screen. Call or email any questions or comments you may have for our panel. They will be happy to answer your questions. Certainly, if you call, we'll answer your question right away. If you email, it might take us a few minutes to get to your question, but we will certainly address it as our program goes on today. So don't be shy. We have a wonderful panel here for you today. Today's broadcast is produced by the South Central Preparedness and Emergency Response Learning Center and in collaboration with the Alabama Department of Public Health. Funding for the center does come from the CDC. If you would like more information on the center, please visit the website that is listed there on your screen. As I mentioned, we do have a wonderful panel here for you today to discuss this topic, and I would like to turn things over now to James Blumenstock. He's the Chief Program Officer for the Association of State and Territorial Health Officials. He's going to be serving as our moderator for this discussion today. Jim?
Chrissy, thank you very much for that outstanding introduction. This broadcast is brought to you through a collaborative effort of the South Central Preparedness and Emergency Response Learning Center, located at the University of Alabama at Birmingham School of Public Health, and the Emory University Preparedness and Emergency Response Research Center. Both centers are funded through a cooperative agreement with the Centers for Disease Control and Prevention. In June and July 2010, the Emory Preparedness and Emergency Response Research Center conducted a national internet-based survey of 64 city, state, and territorial immunization program managers to assess their experiences in managing the 2009-2010 H1N1 influenza vaccination campaign. In this survey, Emory investigated how states' immunization program policies and procedures helped or hindered their ability to manage their response to the pandemic. Survey results highlighted ways in which immunization program managers can work with emergency preparedness programs to optimize future responses to public health emergencies. Strengthening collaborations between emergency preparedness programs and immunization programs will help build surge capacity, to improve decision-making around allocation of scarce resources, and enhance immunization registry utility in emergency situations. Many states, city, and territorial immunization programs and emergency preparedness programs established working relationships and engaged in exercises and drills prior to the H1N1 outbreak that improved the efficiency, management, and resource sharing during the vaccination campaign. Others face challenges with collaboration and communication. The purpose of today's broadcast is to expand on this discussion by convening a panel of national subject matter experts from both sides of the table to address national policy recommendations developed by the Association of Immunization Managers in an effort to uncover best approaches to achieving goals outlined in the recommendations. Based on their own experiences, our panelists will discuss successes and challenges, as well as identify how successful relationships can be forged and maintained between programs to improve emergency response efforts. Now, it's my pleasure to truly introduce to the audience our panelists today. We have three states represented from both the preparedness and the immunization sides of the table, as our introduction said. But clearly they're team players, team partners, and collaborators. Our panelists have been selected using several criteria. Number one, clearly their successes are recognized by their peers around the country. And secondly, they've been willing to spend the day with us to share their experiences, their lessons learned, and maybe some advice on how best to build the collaborations within their jurisdictions and around the country. As I mentioned, we do have three states represented here today, so it's my pleasure to introduce to them by state, and they will share with you their name, their position, and a little bit about their experience within their organization. So first we have the state of Wisconsin.
My name is Dan Hoffensberger. I'm the manager of the Wisconsin Immunization Program. the state of Wisconsin. I've been with the immunization program since 1979. I've been the program manager of the immunization program since 1996.
Thanks, Dan.
Hi, I'm Joe Cordova. I'm the Strategic National Stockpile Coordinator for the state of Wisconsin within the Wisconsin Division of Public Health, and I've been with the department for, since 2003. I retired from the Air Force.
I'm Barbara Ludwig. I'm the Immunization Program Manager in Nebraska. I joined the program in 1995 and became the Program Manager in 2003.
I'm Chris Newland, and I'm the Preparedness Coordinator for the state of Nebraska, and I began my public health career as a nurse in the immunization program and then was the coordinator for the immunization program, moved to disease control and epidemiology, and I'm now in preparedness.
My name is Andy Mullins. I'm the Director of the Center for Emergency Preparedness with the Alabama Department of Public Health. I began my public health career in the immunization department and then moved into emergency preparedness several years ago, and for the last 4 years have served as Director of Preparedness for Public Health in Alabama.
Winkler Sims. I'm the Immunization Division Director with the Alabama Department of Public Health. I'm in my 32nd year with both the department and the immunization program, and the 11th year as the Division Director.
Great. Well, again, to all of you, welcome. We didn't tally how many years of collective experience that you have, but trust me when we say that it's quite impressive for the six of you, for the amount of level of service you provide, not only in your state at this time, but in your career. So again, thank you for that. The first question I want to pose to you all has to deal with the title of today's program. Embedded in the title is the term integration. And we've used this term in the title as a way to best characterize efforts to strengthen relationships between preparedness and immunization programs in each state and across the country. But really, when you think about it, that term may mean different things to different people. So we thought this would be a great sort of jumping off question to turn to each of the three states and have us share with you in your own words, what does that word integrate or integration mean to you, both philosophically and operationally, as we talk about sort of building stronger programs and partnerships within your jurisdictions. So maybe we'll start with Wisconsin and go around the table.
I think integration for us is being able to work together not only on a programmatic level, but also on a personal level. We have a relatively small staff within our programs. And we have been able to collaborate together quite successfully. I think actually when Joe came on, when we first brought preparedness staff on, they were brought on in Wisconsin under a dual use type of scenario. They brought the SNS coordinator within the immunization program because we had the experience in delivering pharmaceuticals. Joe came on within our program. He was hired on our program and worked for us for a while and then broke off into the separate preparedness unit. That gave me, as the program manager, a good idea of how the SNS was supposed to work and how we were supposed to distribute those materials, and I think it gave Joe a good idea of how the immunization program worked. So under the scenario with us, with the dual-use philosophy at the beginning, I think it integrated the programs quite nicely within our Bureau of Communicable Disease, which is now Communicable Diseases and Emergency Response. And I think that worked out well for us in that respect.
Great, thank you.
Yeah. I would just say teamwork. We have a common goal. An H1N1 hit, we were all concerned with getting people protected, getting people, saving people, whatever was necessary, and whether that countermeasure was an antiviral or ultimately the vaccine. It was all the same goal.
Great, excellent. Nebraska.
We have always worked very strongly together. We have very small programs as far as staffing, and to get things done, we've had to integrate what we needed to do. And at one time, we were all in the same unit. We're not in the same unit, but we're in the same division. We have very strong support from our administrative leader. And as you heard Chris mention, she has been in the immunization program, and one of her staff persons was also program manager before I was. So we have worked together both philosophically on how to do this as an agency a project, but also have gotten our hands dirty actually doing the exercises throughout the state.
Again, as Barbara was saying, we work together on a daily basis. It's how we get our work done, not only at the state level, but we also rely on our local partners, both on the preparedness side and the immunization side, in order to get our work done. Without relying on each other, we can't get it done. We're a small state with small staffs, both at the state and the local level. And the good thing is we have to wear a variety of hats. And so we, in the preparedness program, have knowledge about what goes on in the immunization program, and the immunization staff and other staff in the agency as well have participated in our preparedness activities, training, and exercising.
Excellent examples. And the home team, Alabama.
As we put together our plans and began to capture and put them on paper, we worked very collaboratively between the two organizations. But I think what happened as the event unfolded was what had been put on paper did not always match what was happening in reality. And as we began to lay aside portions of what we had captured on paper, the one thing that did survive was the relationships that were built through the process of capturing the plan onto paper. So when the paper didn't work, the relationships did. And we were able to communicate, to share, and to understand where each person was coming from, so that that gave us a much stronger response overall.
I agree with Andy. In most cases, Andy worked in the immunization program, so he understood that part of the whole process in H1N1, and that was an extreme advantage for us, I think. In most cases, if we had any issues we had to address, I could go down to Andy's office and we'd start talking and trying to anticipate what was going to happen prior to meetings or something else that we had to prepare for, and he'd be shaking his head in agreement before I'd ever finished the statement. So he basically understood everything I was fixing to say. So we had real good collaboration and worked well together, and thought we had pretty good success in pulling the event off.
Great. Well, again, thank you all very much. I mean, to me, one of the most common theme is the issue of relationships. I think you've all touched on sort of that professional commitment to working with colleagues within your organization, much more so than sort of the institutional elements of lines and boxes on a table of organization that sort of drives, forces collaboration, as opposed to professional courtesy and investment in that program and developing relationships.
It was always just the professional relationships that were key to it. I think you mentioned it as well. It was the personal relationships you developed over the years. It's a situation where if you do something wrong, you can call a guy an idiot, and he knows you're not taking him to the woodshed. That you've developed that relationship where you can have that rapport back and forth. And that, I think, that was important for us as the two programs worked together, especially when things got heated. That you had those relationships, you developed those over the years, and they really came to the fore when you needed it.
An excellent point. Thank you. Other questions on that one particular issue before we really get into sort of a deeper dive on many of the points that you've raised? Well, hearing none, the next question I wanted to share with you, and you all sort of touched upon reflecting on H1N1 as the last most significant event that really brought the preparedness immunization managers and directors together, as well as your respective staffs. I mean, and clearly you all share the same mission space and the same responsibility of protecting the public from vaccine-preventable diseases and illnesses. It could be basically day-to-day, outbreaks, if you will, to those that are sort of, epidemic or pandemic in nature. So, as we talk about going forward, the best way to do that is to reflect on our performance and our actions of the past. So I'd like to, again, ask each of you from the three different states to share with the audience your greatest success, I guess is the best way to characterize it, with regards to your relationships and your partnerships between the two programs doing the H1N1 response. And it could be a success, but also it could be a lesson learned, and maybe if you had to do it over again, you would do it differently. So maybe let's start with Nebraska. When you think back in 2009, 2010, when both of you individually and your teams are sort of thrown in the trenches to respond to what could have been a fairly significant global crisis. What was your best success working together as a true integrated team?
I think our vaccine allocation and then the delivery system. In the preparedness program, we have an individual who has done a number of spreadsheets that help us quickly determine how to allocate resources, whether it's vaccine or whether it's supplies. And we were able to put that software into place. But I think the more important thing was, as we looked at the uncertainty as to when vaccine was coming in, and we were also working with our local health departments, we had to determine how we were going to send it out and who we were going to send it to, how would we initially send out very limited quantities of vaccine. So we worked together to try to problem solve that. And Barbara's area has the software for physically tracking it. Her personnel have the expertise in sending it out, and so we relied on each other. We didn't step on each other's toes. We listened to each other. There was a mutual respect for each program's skills and knowledge, and we sat down together and worked out the details, and then her area was able to concentrate on vaccine delivery while we were able to concentrate on communicating with our public health partners, looking at the broader epidemiology prevention picture in partnership with our epidemiology staff.
Thank you. Thank you.
And we used systems that were already in place because we give vaccine to a lot of providers throughout the year, and we just modified that to include anybody who was willing to do H1N1, and that was really determined from the local level because we used our preparedness model to send it out to the district health departments, and they worked in their communities to find and identify the vaccinators, and then we had all of that and put it in administratively and all the stuff that you have to do to get it into a software machine if they weren't already in there. And it worked very well. If we didn't get enough allocation at the beginning of the H1N1, sometimes we had to hold it because whenever there was any allocation going out, it went to everybody. So everybody got something each time, so nobody could feel that they were being slighted in any way. But sometimes it was way too small, so we maybe had 2 days' worth on that. And as we moved along, we found that we needed to modify a little bit because even though we had everything identified about how much population there was in every county, one of the things we had not clearly thought about at first was the concentration of healthcare hospitals and teaching hospitals. And we had stronger population in Omaha with a lot of healthcare workers, faculty, and students in 2 teaching medical hospitals. And so we needed to modify that, and providers in other areas of the state, once they heard that there was an issue and that was a problem, donated part or all of their allocation at certain times.
That's great. Excellent. Great examples. Alabama.
I think one thing we worked on that was a success was our website. And starting out, we were able to develop a website that allowed providers all across the state to place orders on there. Early in the event, the federal government wanted to know how many doctors had signed up. Well, we had all their license numbers preloaded. Every one of them in the state of Alabama was preloaded in the system. They were able to use their license number after we gave them a sign-on ID that they could access the system. So it was wide open to all doctors throughout the state and hospitals to become vaccine providers during the H1N1 event. And that was, I thought, was pretty successful, and we were able to come off there with a lot of spreadsheets and other information sources to give Dr. Williamson and the ICS all the information that they needed to know who was ordering the vaccine, where they're located, how much we have as far as allocations, and how much of that we can allocate to them, even though it ended up being 100 doses or so for some period of time. But it did allow us to track vaccine usage, ordering, and be able to give that information to Dr. Williamson, who can make the command decisions on what we want to do next.
I think the information flow is one of our strengths, having that ability, because very often when we were told this is how much your allocation is going to be, we would plug that in and have our plan worked out, only to find when the allocation came, it was not what we had anticipated. So we had to have some ability to change that very quickly, and our IT staff stepped up and did a phenomenal job in providing us the access to databases that we needed to make the allocations and to change them as the numbers changed.
I'd go back a little further. I think when I first started, looking at how to put this whole strategic national stockpile plan together, we looked at outbreaks and how were those outbreaks handled in the past up to 2001. It was typically with vaccines. So we took a lot of information that had already been out there from our locals and from the immunization folks that had been there for a while about mass vaccination clinics. We developed mass clinic plans so you could dispense or administer vaccines from. And so when the 2009 came around, we had the vaccine, they had mass clinic plans. The locals had, enhanced these plans that were there. So, all that planning had paid off.
Excellent, excellent.
I'm smiling a little bit. I'm glad he brought that up. We had individuals within our staff that were around during the swine flu experience in 1976, so we were able to draw on that experience, and that was very helpful because although this changed a little bit and the mode of delivery was a little bit different, the idea of mass clinics was still the same, so that was very helpful. I think some of the other things was, again, going into the collaboration thing. We would go to meetings together with the public and private partners out within the state where it wasn't just the immunization program going out to talk about something. It wasn't just the preparedness program. We would go out together. So we were delivering a joint message and getting the joint message back. So I thought that was very helpful. We did, during the outbreak, we did a lot of communication, and we might be talking about that later. We did weekly conference calls or media site lives, this type of presentation to our public and private partners, which we were able to communicate to them the situation that was going on, and that was overwhelmingly successful. We got a lot of positive feedback on those type of things. And as was mentioned otherwise, in other areas, when the allocations weren't what we anticipated, there had to be some decision-making on the fly. And our ability to work with our public and private partners to bring them into that decision-making process, I think really helped us a lot too. And relying on the local health departments to give us an idea of what was going on the ground more so than we were able to gather all the time within just our area being in the central office. I have to also say our division, our administrative support was done very well, both at our division and department level, where we had the support we needed. If we had a problem, they would help us get through those problems, so that worked out very well. And I think we'll talk a little bit later about our Wisconsin Immunization Registry, how that was successful. I think we're going to talk about that with registries and that type of thing later, but that turned out to be very helpful within the process, and some pre-planning that took place prior to H1N1, and I think came to help us very much. So.
Yeah. Dan, definitely hold that thought. We'll come back to that. And I think, all of your experiences and your illustrations were outstanding. And, the one thing that impresses me, and if I didn't have the opportunity to know some of you for many, many years and just spend some time with new acquaintances in the last day or two, I couldn't tell who was the immunization manager and who was the preparedness director by your comments. So to me, that gives a strong sense of that integration and that collaboration. There's no sense here that they don't understand my world and I don't understand theirs. I don't know their terminology and they don't know mine. So that tension that exists in other disciplines, whether it be within public health or other state agencies, clearly by the illustrations from the six of you from your three jurisdictions, you've definitely seemed to sort of overcome that and have really created that type of rhythm that develops really good program services and operations. But you also possess your own area of expertise and responsibility, so you could still discharge your mission and your unique role, but yet still be sensitive to the other components of the overall state response team. So, again, thank you for sharing that. So that was sort of reflecting over the last 2 or 3 years. Now let's look forward. Short term, in the next year, or even the next couple of weeks or next couple of months. All of us have had the opportunity to talk in the last couple of hours, and for those of us in this field know it's grant writing season, both for the public health emergency preparedness and the hospital preparedness program cooperative agreements, but also with the 317 immunization cooperative agreements that will be coming up shortly. So what I want to do is get your reaction from what we understand will be new language. It already exists in the FEP cooperative agreement grant guidance, and we believe it will be included in the immunization program guidance. Specific language sort of compelling immunization and managers and preparedness directors to better collaborate, better coordinate. So let me read to you the language that we believe that either is or will be in your grant guidance. So for the immunization program guidance, it will probably state, work with preparedness programs to assure preparedness for influenza pandemics and other events requiring a vaccine response, including updating, exercising, and maintenance of plans. And then we know that the FEP cooperative agreement grant guidance says FEP awardees should work with immunization programs and other partners on syndromic surveillance and other activities to assure preparedness for vaccine-preventable diseases, influenza pandemics, and others requiring a response. So, your reaction to that, I mean, what does that actually mean to you? How is that either validating your current strategies and tactics for this integration and coordination, or sort of suggesting that you either ratchet it up or take it in a different direction? So let's start with Alabama.
I guess our relationship will not change. We've gone through vaccine shortages, we've gone through H1N1, the flu pandemic, and come out with the same relationship of working together. So I don't think that's an issue on there. We continue to offer vaccine and do exercises with flu vaccine all throughout the state and the county health departments. They have mass clinics every year exercising the EP grant objectives. So we do work with that and plan to continue doing that.
So as an immunization manager, this is business as usual, this is routine, and this is just, continuing to move forward.
Right. We're in 11 public health areas, and we have immunization managers and EP folks in each area. So when we do these clinics, they're all involved with it. So it's basically the whole department coming in and exercising these, and we try to help each other out and get the effort going, and then they do the clinics and everything out on the local level.
Great. Andy.
I think it's a continuation of business as usual, as you said, for us, because the collaboration has been there for years, and now it is one requirement in our grant that we go, oh, good, we've already done that one. So there's a little bit of relief in that. But I think it does help us. When we go to write a mass vaccination plan, why should the Center for Emergency Preparedness try to write that which is not our expertise? We need to look to Winkler and his staff, because that's what they do every day. So if we can incorporate what public health does every day into our emergency preparedness plans, then it flows smoother, and it's the way we're really going to respond, not some fictitious plan just to meet a grant requirement.
Excellent. Wisconsin.
I would have to agree. I think we already have those things in place. We have a pretty good collaborative effort, a pretty good partnering effort going on already within our program, so I don't see any change in that. We take care of the immunization part of it. They take care of the other things as far as preparedness and the planning for those type of things. But as far as surveillance is concerned, that is another section. That's with our communicable disease epidemiology section within our bureau. So we have those things in place already. So I don't anticipate too many changes in respect to how now we must do it as opposed to, which is, I always find that interesting. But I think we always have the things in place that we will continue to be successful with.
Great. John,
I would say the same thing, and even more so at the local level. When we look at the planning that goes on at the local level, we get a lot of push on the S&S side to plan for anthrax. Our technical assistance tool is anthrax. Everything in the S&S is kind of flavored anthrax. But, our locals, and we know that it's not going to be anthrax. It's going to be pertussis. It's going to be measles. It's going to be another pandemic, most likely, before it actually becomes anthrax. So, that stuff is already being done. And, this, when saying we have to do it, I think is, again, for the grant, it's easy because we've already got it done.
Yeah. Actually, Joe, we'll let Nebraska answer the question, but I do want to come back to the point you raised regarding local health departments and their fit into this integration. So we'll come back to that in a few moments. Barbara?
We've already done it too. In fact, we were involved at the beginning when the preparedness plans were first started. We were part of the table and came up with helping get those put together. So we've kept up throughout the years, and it was just the right thing to do, and so we did it. We also have been involved in exercises throughout the years, and we do have the inventory control over the national stockpile S&S exercises and stuff. So, we are integrated already.
Excellent. Chris?
I think one of the things we haven't talked about, because basically, what everybody else has said, we agree with. One of the things that we do actively is have regular telephone conferences with our local health departments, and we have those on a monthly basis, and then during H1N1 we increased the frequency. We were even having them once a day. Routinely on those conference calls, it's the immunization program is included, our community partners are included, our public lab is included, all of our health departments are included. During H1N1 we had Department of Education there. And so it's an ongoing activity to communicate on a continual basis with the local our local partners and our state partners, so that once again we know each other not only professionally but we know each other personally, and the relationships are there. Then we can talk about our strategies, what our problems are, how we're going to resolve an issue. When a neighboring state decided to open up their vaccinations to the general public, we immediately pulled together an emergency telephone conference with all of our partners, and we were able to do that in an hour and a half. And we had everyone on the phone, and we discussed whether or not that was appropriate for Nebraska at the time, and it was not. We were going to wait a week. And as part of that telephone conference, then we also agreed on what our communication strategy was going to be to the general public, so that we could justify why we were using a different approach for that 1 week time period than our neighbors across the river.
Excellent. Thank you. So let's play off that for a moment. So, 3 states have, local health systems of different size, shapes, and forms. But the fact of the matter is they exist. They are critical components into sort of the enterprise of this nation's public health system. So when we talk about the issue of strategies and tactics, of how to not only satisfy or comply with the grant guidance, but more importantly to build a stronger, more effective, integrated public health immunization, preparedness and immunization response. How does your behaviors, your philosophies, and your leadership really impact sort of creating that same level of relationship and harmony and progress and performance at the local level? Does it come naturally? Are there special efforts or special approaches that you would take to ensure that local programs are as integrated, if you will, as it is at the state level? Wisconsin, any additional thoughts or ideas?
I'll start with, when I first started, I came from the Air Force, and planning in the Air Force is very different than planning in public health or in state or county government, I'll tell you. I was explained, I developed, Dan said, develop a plan. I developed a plan. I gave it to the locals, and the locals explained very, very detailed how this wasn't going to work. And so it was a lesson I learned that we needed to, I needed to understand what was happening at those health departments. And we have municipal health departments, we have county health departments, we have tribal health centers. They all act a little bit different. They're all different sizes. So it's really just getting an understanding of what's going on. And most of it is that day-to-day activity. How can we, for preparedness goals, take what they do every day and turn it in, make a tool that works, for preparedness and the day-to-day stuff. And again, that's why, the vaccines is such an important part of that, because that's what they do, that's what they know, and it's easy to relate back. If you can administer a vaccine, which is actually harder than handing someone pills. The hard part of handing pills is the screening, and so we're working on tools to help everybody with that as well. So, that I think was the big part, is getting to really know those health departments, understand all the different things that they do that make public health every day.
Yeah. So in many respects, you lead by example, but also local health, has very clear expectations on what types of services and support they expect and need from state health departments as well. So that relationship issue is key.
Well, they know what the needs are within their communities.
Yeah.
We can do a certain amount of planning from the top down. It's like the federal government coming to the states and telling us, how they think we should go. We appreciate that leadership and that direction, but it's got to be modified a little bit at the state. It's got to be modified a little bit at the local level, because they know when the rubber hits the road, they know how to react to those type of things. So you really have to rely on that type of expertise. We look to them to make sure that there was adequate clinic capacity, whether it be at the public-private sector within their communities, and then we would try to respond to giving them the vaccines they needed. We are in Wisconsin considered to be a home rule state, where the local health departments are a function of the local government. So it's not like we can compel them to do certain things unless you can hang that funding over their head a little bit. But that I think had to be taken into consideration when Joe comes from the Air Force and develops a plan. But by the same token, they understand where we're coming from, and I think try to help us through that, so it's not pushing against each other. I think the relationships within our public health departments in the state, there's always going to be little things here and there, but when things get tough, they're there for each other, and we really work together pretty well.
Excellent
I think.
points. And then on the other end of the spectrum, you have a local design in the state of Alabama, which clearly is not a home rule state. If you could just share with us your experiences and maybe some suggestions for the way that you advance your strong relationships in the community.
We have 67 counties in Alabama. 65 are a part of our centralized health system than two independent counties that, from a practical standpoint, function as a part of our system. So it's very seamless. And while we have the authority to push mandates down, I think it's important for us to remember that public health doesn't happen in the central office. Public health happens at the county level, face-to-face with those patients. So we try to keep that in mind as we prepare a dictate to pass down. I think it's important that we keep in mind the people who are meeting the patients and the clients face-to-face and consider their input, because without the counties, the state office has no purpose.
So, Winkler, anything?
I agree. We're in 11 public health areas, and in H1N1, each of the area administrators was the incident commander for that area, and they had their individual counties under those. So now, since Alabama's not in districts, we're not in independent county health departments, are all basically operating under the same umbrella there. So, and we're a little bit different from other states in that we're not an appointed position. We've had basically 3 health officers over the last 50 years. So in that sense, it makes a lot of continuity in there. Everybody knows what they're doing, so you don't lose a lot of knowledge when somebody's leaving. And the average stay of a health officer, I think, is maybe 18 months. So we're quite in good shape in that sense there. But the local level is where everything happens, and they're the ones that are going to pull it off, both in their clinics and in setting it up with the local administrators or the local governments to make everything happen. And I think it's really important, like Andy says, and everybody else, to remember that everything is, like I think Tip O'Neill said, all politics are local. Well, all public health is local as well.
We've heard that, absolutely, right. Well, you know, this most recent conversation was sort of, you know, teed up through the issue of grant writing and the cooperative agreements. So obviously, you know, federal cooperative agreements to states, you know, brings resources along with technical assistance and support from our federal partners. But what we want to do is spend a few moments talking about resources, because clearly the public health emergency preparedness cooperative agreements and the immunization programs in states are fairly large cooperative agreement programs, certainly mature programs by many people's standards. But, you know, they're dwindling. You know, federal resources are having a downward trend. We know what the impacts of state and local budgets are on discretionary funding and how that's impacting many of our program areas as well. But you all are still expected to do the best for what you know, with what you have, and to basically maximize the effectiveness and efficiency of every resource provided to you. So share with us some of your tricks. You know, exactly, you know, what conversations, what approaches are you following that would really give you the opportunity not only to pool resources from both programs, but to leverage each other as well as other interested parties, really to provide, you know, enhanced and improved services to the community. Start with Nebraska.
We have separate budgets, but the immunization registry, I think, is a really good example of where we were able to pool some resources, because through the generosity of Wisconsin, we were able to use their immunization registry at no cost, and the immunization staff are responsible for it. They do the training, they do the exercising of the opening up of the inventory component of it, so that passwords don't expire. So they have done that, and so we in the preparedness program haven't had to worry about that particular aspect. In terms of staffing during H1N1, we used our preparedness dollars to help get some temporary staff. While our hospital funds and our preparedness funds are combined to pay for staff, we don't pay for any of the staff in Barbara's area. However, Barbara's area contributes to an epidemiologist, and our preparedness dollars contribute to an epidemiologist. And so together, we can maximize our assets in that particular way, so that we can support the epidemiology and the surveillance, the syndromic surveillance that benefit all of our programs in public health.
Thank you.
Also, early on, I think that we came to an understanding of who was going to do what part of the tasks, and where the leadership was going to be and how we worked together. So the two programs were not both trying to do the same thing. So that way, Chris took the lead on the administrative of getting things out and the deliveries, and we did more subject expertise in the vaccines and the ordering part, and then integrated where we needed to.
Great, great. Alabama or Wisconsin, anything more to add?
I guess on our side, Andy and I talked a little about it. You know, job descriptions on each individual you have that you have to participate in any emergencies. That kind of helps, but you know, in no way could you go to the incident commander and say, well, I'm not going to do something because it's not in my grant funding schema. It just doesn't work. So the most part, you know, we always said when a flu pandemic comes and everybody in the department is going to be involved with it, and that's basically how it works out. And you work on the funding issues as a side thing. I think, you know, Andy knew what's going on at CDC, when funding's coming across, when it's going to happen, and all that. So everybody relied on him to do that, and it all flowed. When it came down to working out the budget, we had, just like everything else on whether it's vaccine or funding, you had numerous meetings and daily meetings and all that, trying to figure everything out. So it went really well, I think.
I think another key to that was cross-training. It's one thing to say, okay, in an event, everybody has to respond, but it's very different to take a nurse who has been working an STD clinic for 20 years and suddenly say, tomorrow you're going to be giving immunizations. So it was important to have a mechanism for just-in-time training to refresh those nurses in skills that they may not have used in a while so that they were comfortable and competent to go in and do that. So I think the ability to use some of our training nurses out of EP to help them improve their competencies and confidence levels is important because it's more, as I said, than just saying, go do it.
Yeah. So let's pause at that one point. So cross-training, obviously, between the emergency preparedness and the immunization program services. But what other elements of your agency or department did you bring in for cross-training? I mean, you know, clearly there are many possibly clinical services provided by other branches of your agency, skilled individuals that may have an interest in volunteering and stepping up. You know, how did you, for Alabama, and then we could go around the table, how broad of a call have you put out for volunteers for cross-training, and what barriers did you have to overcome?
I think the biggest barrier we had to overcome was people's reluctance to step out of that scope of practice that they've been working in for years. There is an element in which they're comfortable, but to step out. And our current nursing director, Dr. John Hankins, told all the nurses, if you are carrying a nursing license and work for this agency, we expect you to have a certain level of competency in basic nursing skills. But we at the same time offered some remedial training for people who hadn't practiced certain skills in a while. And that has made a huge difference for that, because Alabama responds to 6, 8, 10 emergencies a year. So it's not unusual for immunization nurses to be working shelters along with the EP nurses. And during H1N1, the EP nurses were in line with the immunization nurses providing immunizations to people. And the same was true for nursing who've been in administrations for years and probably hadn't done hands-on clinical, and yet they stepped out and said, okay, refresh me and let me go.
They probably loved that opportunity.
Many of them did.
Yeah,
Some of them were a little hesitant, but many of them loved it.
True all hands on deck type of philosophy. Nebraska, anything to add?
One of the things that we did towards the end of H1N1, we had vaccine that was left over. It was short in the beginning, but heavy in the end. So we decided to hold a small immunization clinic in our building, and we pulled in nurses from throughout the agency. I mean, we had the PRAMS program, we had somebody from HIV, we had somebody from the refugee program, we even had a pharmacist who was helping, and everybody, we set up our clinic, and many of these people had never given shots in a long time. So they got refreshed, did it. It was a wonderful experience. They're ready. They're eager, in fact, to continue to be called on when they're needed for that.
Excellent, excellent. And again, you know, the point we made actually in the car driving up here, it's there's strength in numbers. When you hear two strong programs like preparedness and immunization, issue a call to arms, so to speak, within an agency. I mean, certainly their state health official, sort of could appreciate that wisdom of the two programs to mobilize the full forces of the agency. Wisconsin.
Well, yeah, and I think it actually goes beyond preparedness and immunizations. We had, for H1N1, we had our environmental health. They were doing the planning in our ICS structure. Everybody's had ICS training, everybody's had NIMS training, so they were doing the ICS, the planning and stuff. We had other folks doing logistics to get the things that we needed to be able to operate, all of those kinds of things that were going on. And besides H1N1, we looked at, in 2008, Wisconsin had, we had 72 counties, 30 of them were flooded underwater. We had people from, this was more of an environmental, so we had folks from all different areas working, taking roles, communicating to folks, just to make sure that, all of those things got done. So, it's kind of, when something comes up, everybody's involved in it, and I think definitely through preparedness, the ICS training has really, helped out tremendously.
Great. Excellent.
I would have to agree to that. That's the same thing I was going to say as far as the ICS training, the Incident Command Structure training, I thought was very helpful to the different programs and to the staff going down, because so when they saw that org chart coming down on where they were and what they were doing, they had a good idea what that was. When we went through the ICS training, we're thinking to ourselves, geez, this is a lot. But when the things hit the fan, it was there, and you had it in your back pocket, and it really helped you as far as being able to plan and go forward with the structure of things and how they were supposed to work. So I thought that was very helpful.
Excellent. Maybe a follow-up question is, in your experiences, I mean, I guess I'll pose this question to the preparedness directors. I mean, are you sensing that the immunization managers are basically have set the standard, if you will, of sort of embracing the incident command structure, of going into the training? Or are they comparable to other disciplines, whether it be environmental health, radiation protection? Are you sensing a difference in the level of interest or commitment from program to program?
Well, I'll jump into that one right away, because we have gone through measles outbreaks, we've gone through pertussis outbreaks, where the local health departments have implemented an incident command structure within their health department so they can mobilize the staff to respond to the different outbreaks. So I think in that respect, there's carryover from preparedness, as it were, for a disaster, or the everyday things, as we're going to see more often, the pertussis outbreaks, the measles outbreaks, where they've implemented that incident command structure, and it's been helpful for them. We implement it to a certain extent at the state level for a pertussis outbreak or a measles outbreak, but I think many of our health departments find that very helpful to be able to mobilize staff into that one unit during that.
A classic example of integration. That question was answered by an immunization manager.
Jim, I did want to touch a little bit on the leverage thing you talked about before, the funding thing. Within our program, we give money out to the local health departments in the form of performance-based contracts, where they had a set of objectives that they're supposed to accomplish. It's primarily in the area of childhood immunization, so it doesn't touch too much on the preparedness side. Unfortunately, as you also mentioned, funds have stagnated where we haven't, for the last 5 or 10 years, our level funding has been level in that respect, where we're asking them to do more with the same amount of money. With less, actually, with inflation, as it were. So that is difficult. I think where we've been very successful, and Chris alluded to it, is leveraging funding from preparedness in the area of surveillance, but also in the area of the Wisconsin Immunization Registry, the system we developed. We developed a module to manage the assets of the Strategic National Stockpile. I'll let Joe touch on that a little bit. During the H1N1 situation, we had the ability to enter information into the system, but it went through all the immunizations that were there, where during H1N1 we implemented a mass vaccination screen where it only dealt with H1N1 vaccine, or the one vaccine you're dealing with in that mass vaccination. And then post H1N1, we leveraged some funds from preparedness, or a fairly significant amount of funds, to revamp our vaccine ordering system. We wanted to make it where, like, if you order something online, you get a confirmation back, and you're able to track it. So you know your order's been received, you know it's been placed, you know it's been shipped. So we're working on those type of things, leveraging the preparedness funds in order to do that, because, again, we know it has dual purpose. It's going to help the immunization program, but it really would have helped us to have that capability during the H1N1 situation.
Excellent suggestion. Joe, anything to add on that?
Yeah, we developed the SNS module, which tracks all of the items from the Strategic National Stockpile. If they bring a pushback in, we can upload the data into the immunization registry. And what that does for us is it allows the same tool that our local public health and tribal health, everybody uses on a day-to-day basis to track vaccines, to order vaccines, to lead inventory. Instead of vaccines, through antibiotics or medical supplies. So the screens look, similar. The nomenclatures are different, but it all works the same way. So there's not this huge learning curve. And that was something that we control, we built, and we've been when fundings are available, we try to enhance it. And if there's other things that can enhance the immunization registry, because the more people that use the registry, the easier it is for us during an emergency to have them use it for that.
Yeah, exactly. And Dan, I mean, the beauty of that example is that not only Wisconsin benefited from the collaborative efforts of building the tool, but sharing among your peers across the country. What works well in one jurisdiction may very well work as good, if not better, in other jurisdictions. So I think the example of efficiencies and just peer-to-peer support across the country, I think, is an outstanding example. So thanks for raising that. One last question on resources before we move to sort of a couple of other areas. And that's on the issue of, I guess, what has been coined budget or administrative preparedness. And again, when we reflect back on the H1N1 experience, the nation's public health system was clearly appreciative and benefited from emergency supplemental appropriations that Congress provided when the pandemic hit in the spring, summer of 2009. Round figures, I think that meant upwards of $1.5 billion as an immediate infusion of funds to the nation's public health system. The resources were needed, not knowing what the level of severity of the pandemic was going to be. But clearly, just given our legacy systems of processing funds, hiring, procurement, it presented some significant challenges to state and local public health departments, as well as the federal government. So I know there is a lot of efforts underway to try to really remove those barriers and improve our collective efficiency should crisis funding be necessary and made available the next time something hits us. But we need to be ready to be quicker, more agile, and more efficient in handling these types of funding streams. So reflecting on the last year or two, but also as you're going forward, because I know in at least one of the cooperative agreements, you are expected to sort of assess your state of administrative preparedness for these types of budget-ready initiatives. Ideas or suggestions that worked well in your state or that you're putting on the drawing board for future consideration? We'll start with Alabama and go around the table.
I think in Alabama it worked well for us. We have statutory authority to spend grant dollars that come in, whether they are routine or emergency. So we did not have to wait on a state legislature action for us to spend the money. So as soon as we had the notice that we had the award, we could proceed with it. The other thing, in a state of emergency in Alabama, we have some much more leeway in making emergency purchases. We don't have to, for example, go through the same bid process and quote process, so that we can make much more speedy purchases or decisions regarding those things. So I think the system that was put in through the years has really benefited us in this situation.
Great. Good for you. Nebraska, anything to add?
One, we've talked a lot about relationships, and I think relationships was key in our ability to work with our local health departments and their other partners in responding to H1N1. We were able to get the monies out fairly quickly, but it still takes time to develop and issue a contract and get those contracts signed, or subgrants with our preparedness partners. And no one hesitated, no one delayed any of their activities based on the fact that they did not have a signed agreement in hand at the time. They knew what needed to be done, and they did what needed to be done, and they knew that the signed subgrant would be coming. Didn't know quite when, and as the federal government continued to go through phase 1, 2, and 3, trying to get those documents out became increasingly challenging, but the work was getting done, and it was based on those strong working relationships and trust.
Excellent point. And I think other states would share with you, share the same philosophy and approach as you just did.
I'll let Joe touch on.
Okay, Joe, please.
Yeah, we received the funding. I think there were a few, red tape issues that we had, but for the most part, one of the things that we wanted to do early on was we wanted to contract with a commercial medical supplier to deliver our. We had a state supply of personal protective equipment that was augmented by the Strategic National Stockpile. We didn't want to be in the business of having to ship this to everyone. We wanted to be, as needed basis. So we ended up working with a commercial medical supplier. The whole procurement process for that, I think, took us 2 days. We started on a Friday afternoon. We had the contract in place Monday afternoon. And I think typically that would have probably been a 60 or 90-day process, normally going through all the channels and bids. So, it did work really, really well there. We needed people. We did have to do, we still had to abide by all the rules that were necessary to do that. So we brought in some National Guard on state active duty. Our Adjutant General supported us very well. We said we need 3 people. They made a call up. We had 3 people the next morning. It was incredible. They were all part-time Guard members. They were getting ready to go to Iraq, so none of them had full-time jobs. So we hired them as limited-term employees until they actually had to deploy to Iraq. So we trained them as Guardsmen. We we kept them, and so that worked really well for us too.
Excellent examples. So what I want to do is take you back to sort of the discussion of relationships. Over the last hour or so, all of you touched upon the critical importance of not only professional relationship, but also personal relationship between the leaders of the 2 programs and your respective programs. But sometimes that just is not good enough to make a difference in the relationships or the performance of the combined efforts of the 2 programs. So let's talk a little bit of sort of like institutional organizational design. You share with us some examples or some weaknesses that you may have identified either in your own agency or elsewhere with regards to sort of the table of organization of programs being housed in different as well as or compared to being in the same organizational unit or team or other things that you have done to strengthen the true performance and relationship, such as possibly embedding sort of the different disciplines in your respective advisory groups. I know for the preparedness folks, you have advisory committees. Immunization groups have advisory committees. We've talked about incident command and emergency operations centers. Is your immunization manager an official permanent designated seat in the health operations center for those events that are vaccine presentable? If you could sort of share with us those types of examples that you have that really reflect sort of the organizational commitment to the integration and the collaboration between the 2 programs. Or if you, again, look at your own organization and say, gee, if we were organized or designed differently, we could possibly be better at what we do. Examples or comments to that?
I think as far as Alabama, the structure works pretty well. We've mentioned the public health areas, but within our own central office here, we had one doctor that was over it. Dr. Charles Wernley was over both emergency preparedness and the laboratory and communicable disease. So he kind of hit all 3 levels right there, so it worked pretty well. But now that he's retired, we're seeing a split between we're under a new person that's come in that doesn't know the programs that well, so that's an educational issue there. But then Andy's on under another person, so instead of us having a straight line to one person, we've now been split in different directions, but the relationship still has to go on. And that's one thing that we'll continue to work on. I don't see any issues there. Just like incident command is a huge educational issue on that, of wherever you are in the boxes or where you're in the structure there, you've got to be able to educate folks and tell them what you're doing and what you think is going to happen to have the outcome that you need to handle the exercises or the incident that's going on at the time.
Yeah, so you're successfully adapting to the change. It just, you just have to do things a little bit differently and until you get to that point where you're very comfortable. Andy, anything more to add?
No, I think 1% it up. With the agency making some changes, we are in different relationships structurally and formally, but not interpersonally as we work together.
Excellent.
Well, when H1N1, we knew there was going to be a vaccine, so Dan invited me to the Wisconsin Immunization Advisory committee meetings. So I attended those meetings on a regular basis before there was vaccine, when there was vaccine, and after there was vaccine. And it was very valuable for, I think, for both of us to be able to kind of get an idea of what preparedness funding, any of those kinds of issues and stuff. But then after that all died down, kind of go back to where I'm at, because I'm not sure it would really be beneficial for me to go to meetings on it now. But I think the ability that we know each other well enough to say, hey, this is where you should be on these kinds of meetings and stuff. And I think we do the same thing with the immunization.
So if, as a nation, we were to ramp up on some aggressive planning for another threat agent that would have a vaccine, so, you're just using smallpox or anthrax as an example, you feel that you basically could easily and seamlessly flow back into that relationship with the advisory committees to discuss new or emerging topics.
Right. Absolutely, and I think it's really important, from the stockpile standpoint, because you're talking about vaccines that are going to be coming through the stockpile and that, but just the whole logistics issues of all those things, that some of the things that we've done and maybe can help elaborate on or kind of say why we didn't do things. We've thought about these things. A lot of times when people aren't in preparedness, if something happens, and this happened in H1N1, we got all these ideas. Well, why don't you do this? Why don't you do this? Why don't you use banks? Why don't you? It's like, well, we've thought about it. We've talked about it. We've talked with these partners, but that's just not going to work, and we know why it doesn't work, and this is why, So
Jim, I think
it helps.
Pardon me. It depends on how you interpret your question. Would something like that work at the national level? I'm not so sure.
Yeah.
Because that's on a far grander scale. Like Joe mentioned, if there's an issue that he has to bring forward to our advisory committee, he comes and mentions it, or if there's an interest by the advisory committee on hearing something from them, we have that ability to communicate back and forth, and we'll bring him to our meetings, or they'll bring us to their meetings on issues of mutual importance. Because we have that communication system already set up. Will that work on a grander scale on the national level? I think it probably has to be a little more formalized. Yeah. But for us, it seems to work very well. Our advisory committee, if there's issues, they'll tell us about it. They'll tell me about it, and we'll bring in the proper people in order to address the situation. And like Joe said, it was really good to get their input, because it did reflect public and private sector and academia, and they are not hesitant to tell us what they think.
Yeah.
In a very positive manner, I might add.
Yeah.
But
so let me
helpful.
I guess, clarify my point. So if the U.S. government felt the appropriate need to send a message to states to immediately improve your strategic and tactical planning for another threat agent, again, using smallpox or anthrax as an example. So again, it'd be state-centric, obviously pulling out your CONOPS, your plans, and your other operating procedures. Those, under that scenario, each individual state then would basically rally to that request or that guidance and possibly use their advisory committees as one platform to sort of help frame the issue.
Yeah, that's what I was thinking that you had meant, so that's why I was, again, I'm one SNS coordinator out of 62 different ones, so we share ideas and stuff, and I just think that's a good idea.
Great, excellent, thank you.
I think it's got to go beyond a mandate, though, because when the federal government comes down in our guidance and says, okay, you will collaborate and it's mandated, then very often, okay, we will invite you to come sit on our advisory council and we'll go sit on yours, but if there's not the will to do it, then the mandate doesn't carry much power, because you can do most anything on paper. But it's whether or not the will is there to build the relationships, and that really happens whether or not there's a mandate.
You can't mandate cooperation.
Yeah, you're absolutely right. Great. Well, let's. Our hour is up. So let's just pause here for a moment to check to see if we have any questions coming in from the audience. So with that, let's. We do have a couple of more areas that we sort of want to probe. Quickly, let's talk about other partners in the community that we feel both the immunization and the preparedness programs have spent a lot of time cultivating and benefiting from. Your collective experiences in bringing in sort of the non-traditional partners into your planning and response efforts. When you reflect back on H1N1, sectors such as pharmacists and pharmacies, OB/GYN physicians in the community, even schools. Granted, they have a physical plant where they actually give you the bricks and mortar for certain, clinic services or pods, but clearly they are also responsible for a very precious constituency, our children, that are vulnerable as well. Reflections on how immunization and preparedness teamed up to really bring on board the partners, cultivate those relationships that are almost in a sort of a turnkey mode for the next time an event hits your jurisdiction. Examples?
One of our successes was getting our emergency medical services to be able to vaccinate. We'd had some, they had to go through protocols through our EMS board and all that. And we had some EMS agencies in the state had done this in the past, given out seasonal influenza vaccine and stuff. But we were looking at making it easy for all emergency medical services across the state to be able to do this, to get their medical directors to sign off on the order. So we worked very closely with our EMS section, immunizations, preparedness, to try to get this done. We were able to get this done, and a lot of people really liked the idea to be able to do community immunizations, H1N1 at the fire station or at the school, but it was the local EMS folks doing it. People they know all the time, and it worked out very well.
Great. Did we not put together model policies and procedures for them as well?
Yeah, we did. Yeah, we did all the the tough stuff, the protocols, all of it. They just had to get modified if they needed to, but get their medical director to sign off on it. And it was a bit of a challenge. We did a lot of work to get it there, but in the end, by the time the vaccine showed up in plentiful, it was one more way to get vaccine out to folks.
Nebraska, any examples to share?
Well, I think in many respects, who actually helped implement was left at the local level, because they know they know who they have there. In some places, we don't have a lot of different types of physicians and all. So we did have a lot of pharmacies who helped, and also put all of their registry, all their immunizations into the registry, and continue to do so. But it was also interesting in areas that did have some specialists. We had unique specialists who don't normally give lots of shots, like orthopedic surgeons or plastic surgeons or neurologists. The OB-GYNs, of course, because of the issue with pregnant women, were also very expected to be there. But the other ones were kind of a surprise. Also eye doctors.
Yeah. Excellent. And Alabama?
We had kind of the same situation. I mean, it was interesting to see trying to get vaccine out to providers who had never given vaccines before, the new providers, hospitals, but also in just the health departments trying to work together with the AAP, AAFP, Hospital Association, and all those kind of agencies or associations out there that have links into the doctors to be able to get information out to them. But to see all these folks of varying practices out there to come in to be vaccinators was really interesting. They may have been the employee doctor for the local industry or something, and they happen to work at one hospital. So you're getting a lot of information out to a lot of different people, and it was really good to see the response that we had in the state, and working with all these different agencies and associations and doctors. At the same time, we're trying to coordinate mass clinics at the health department and go into schools with mass clinics, and then also continue to give them vaccine out there in the private sector.
Excellent. Other comments or thoughts on that one? Examples?
I think
Great.
public information made a huge difference for us. We were able to bring together the governor, the state superintendent of education, state EMA, Dr. Williamson, our state health officer, and those key partners together, in fact, in the studio, to do live broadcast to the news, to the public, that allowed them to hear from a unified voice what the state's plan was and what we were going to do, especially early on before the vaccine was available. So that unified voice made a huge difference, I think, for us.
Good, good. Thank you for that. So we actually do have a question from the audience via email. So, Will, could you read that to us, please?
Sure. The question is, can you comment on public-private planning and tactics in regards to retail pharmacies as recipients and providers of the H1N1 vaccine? Were there any statute changes needed?
Great. So for the 3 states that are here, did all of you use retail pharmacies in your administration of vaccine and vaccination? Great.
Yes.
So the question, how much of a heavy lift was it, basically, to get them on board, whether it be, again, logistically, legally, things that would make them make a difference, help them make a difference in addressing your population's needs?
As long as they were certified in Wisconsin, pharmacists can give vaccine to anyone 18 years or older. So what we looked at was, can we get that down to a younger group, and what is that age cutoff? And here again, this was a collaboration with our advisory committee about what age to go down to. It was finally decided on age 10. We asked our pharmacy board for a variation to the rules, and we were granted that variation, so it was allowed pharmacists to be able to vaccinate down to 10 years of age. And it worked out very well. We had a lot of pharmacists that provided vaccine. We had one corporate, they're a grocery store chain, and their CEO said, there's no way we're going to charge for this. If anybody comes in, they get it free.
And that includes the administration fee.
Yeah,
I mean,
they did.
obviously,
Yeah,
a
right,
vaccine,
yeah,
but
free. They did it for free, and that was, they were stepping up because they felt it was their duty to do that. So, that impressed to us that this is a good way to get vaccine out to folks.
Excellent. Nebraska or Alabama, examples?
Pharmacists can immunize in Nebraska, and there is no age restriction, so we had no problem. I think probably the major thing is that they hadn't really done much of it. So we were doing more training on basically the flow and the record keeping and the information that they needed to give for the VIS, so vaccine information statements and things like that. So kind of a pharmacy 101 on immunizations.
We supplied vaccine to pharmacies, and they can vaccinate in the state of Alabama, so we don't see any statutory changes at this time that are needed. So we did supply them. We had, of course, independent pharmacies call. We did have the chain, of course, call. I'm sure they did that to every state, but we didn't have any issues at all that I saw.
So I guess to summarize is, at least for the 3 states represented here, the laws worked in your favor. That it was permissible and even could be modified under certain circumstances. And you certainly had the programmatic will and interest and the logistical capabilities to bring them in and make them an effective series of locations for vaccination. Dan?
So, well, I was just going to mention, and I'm not sure if the H1N1 experience prompted the change, but after, as Joe mentioned, our initial restriction on pharmacists was 18 and above. Now they can immunize down to 6 years of age, so 6 and above. So there was a statutory change.
Great.
And I'm not sure it was in response to H1N1, but they do have that ability. And now they are interested in the Vaccines for Children program and delivering the wider, the full complement of vaccines to 6 and above.
Yeah. And that was sort of the follow-on question I was going to ask, that, through your experiences, I assume you are currently having conversations with pharmacies and pharmacists talking about, other countermeasures for other threat agents as possibly the way in which pharmacies could contribute to the public health response to that? Or is it now, is your conversation still limited to just influenza, seasonal, and pandemic?
We talked with our pharmacy society a couple of times about the use of retail pharmacy and again, going back to SNS anthrax, how can they help us dispense the medicines and stuff? And they felt that really the retail locations weren't really a great idea for the large public to come in. There's not a lot of parking, there's not a lot of room. Most of their business really is retail, and a little bit of it is pharmacy. So they felt that they would be better off helping us at our mass clinic locations, consultation over the phones, those kinds of things, versus actually doing that. So we did talk with them a bit about that, kind of looking to see where's the best fit for a pharmacist. We know pharmacists are great. We can really rely on their expertise when we're handing out pharmaceuticals. So.
Excellent, Joe. Thank you. Christy, we have a question on the phone.
Yes, sir, from Missouri. Go ahead, caller.
For me?
Yes, ma'am.
Hello?
Yes, yes, you're on. Please present your question. I'm sorry.
Okay. I would just like to know, when they were getting ready to distribute the H1N1 vaccine, storage and handling was a big concern for providers that didn't normally provide vaccines. So I'd like to know how they determined whether they had the proper storage units for this vaccine and how they were documenting the temperatures and so forth. And then the second question I have is, how did the states react when they themselves had already contracted or had agreements with the pharmacists in their state, and then CDC came in and supplied vaccine to them above and beyond? How did that affect their state?
Great. So, caller, thank you. So the two-part question is first, what level of assurance and due diligence did you apply to make sure that the vaccine was properly maintained and stored and administered, especially for pharmacies or others that that are not typically part of that effort? And we'll hold the second question till for a few moments. So
we had, as part of our Vaccines for Children program and working with local health departments, for many of our providers, we already had those type of requirements for handling and storage in place. So that wasn't too much of a problem. It was the other non-traditional providers that we didn't normally work with. Many of them were hospital pharmacies or even the pharmacists. They have a pretty good idea on how to manage pharmaceuticals. But they're also, and correct me if I'm wrong, there was within the requirements of being on a provider, you had to receive vaccine, you had agreed to certain stipulations. And one of those hard stipulations was handling and storage and temperature tracking. So to a certain extent, I think we had to go on trust, but if there were concerns with handling and storage, we had the ability to step in and check out to make sure things were being done properly.
Right.
Excellent.
And on our website, we had a website devoted to pandemic, wisconsinpandemic.gov. We put links to cold chain management from one of the immunization coalitions that had great stuff out there. So, it was really pointing people to that if they had questions about, refrigerators, how to keep things cold, all of that stuff. So, give them that information as well.
Other examples?
We also have, in Nebraska, we have some regional nurses who work different territories since we're kind of a long state. And they checked a lot of different places and worked with the providers in their areas to make sure that if they had any questions over and above what Wisconsin did, which we also did, that they had person-to-person. That worked particularly well, I think, with some of the fact that FluMist, the nasal version of H1N1, was not always readily accepted in a lot of areas. And it was also one of the first kinds of vaccine we got. So if you wanted to get your people immunized early, that's what you had to use. But our nurses also worked with them and really kind of walked them through all the research based on how good it was and that there was no problems, and assured them that they could use it. And they were usually pretty trusted because they are the consultants that they usually call when they have questions anyway.
Yeah, absolutely. And if I could just add, Barbara, I know earlier this morning you had mentioned a little bit about the 100-dose minimum quantity presenting some challenges under certain circumstances.
It was. We have a lot of very small towns and very small providers, and 100 doses might be more than they needed. So what we would do is we'd bring it into the state area and repackage it so that it went out into the right amount that they could use, and also along with all of our getting immunization or getting the vaccine out there, we also kept track of who had how much and transferred when we needed it, so that for some reason somebody had gotten more than they needed and if someplace else needed more, we would physically get it transferred.
We ran into a slightly different issue in terms of the storage, and whether it's the middle of summer or whether it was the middle of winter. And in this case, it was the middle of winter, and we ended up having a cold snap. And so the issue was the temperature in transit from our office or the local health department's offices out into the particular clinic site. Because it got so cold, we were having some vaccine that would get too cold. And so we had to get prior arrangement, shall we say, or prior notice when the UPS would be coming, so that either we didn't send it. There were several days we didn't send. We said it's too doggone cold and we can't ensure that the vaccine is going to arrive at the appropriate higher temperature as opposed to lower. So we had to delay some vaccine shipments because of that.
Great. And quickly, Alabama.
We had on our website the provider agreement, I think, that was standard across the country, and within that we had some information on vaccine storage and handling that they had to read over and understand before we'd let them continue.
Great, thank you. So the caller's second question has to deal with the effort undertaken by CDC to get more vaccine out into the community. And I'm sure you all have vivid memories of that approach, whereby they reached out to several large national pharmacy corporations and made arrangements to direct ship to them large quantities of vaccines so that they could more easily deploy across their store base. And also, another strategy was to remove some of the burden on states that were still in the process of managing a lot of vaccine, antivirals, doing all of the disease surveillance, and the public education and communication. So the intentions were excellent as a means to sort of lightening the load on states, but also trying to get more vaccine out into the community to supplement sort of the traditional state approaches. So with that as backdrop into the caller's question, how did that rub you? I mean, and how did it play out in your three jurisdictions? At the end of the day, did it make a difference? Did it improve things? Have any unintended consequences by doing that reaction?
Well, I didn't see anything wrong with it. I mean, you're getting vaccine out to providers and trying to offer more to the public. That's good. I mean, you stop disease by giving vaccines, so there's nothing wrong with that. Well, we did try to get them to give us the information on where it went, and maybe a little bit different story there. But we were doing our effort on trying to get vaccine out there, and then this comes along, and we tried to get them to give us the same information that we've been trying to provide to the federal government as well.
Nebraska?
Pretty much the same.
I recall an inventory management type situation. We had already had shipped vaccine to the pharmacies, so I think we're able to arrange it okay. I don't remember it being a major issue.
Yeah. I mean, from my sense, I think that's a general consensus, that definitely improvement in sort of the visibility on the amount of material, the vaccine being distributed, and what was used, what wasn't, how was it eventually disposed of. But overall, sort of the concept seemed to be generally accepted and helpful. So, caller, I hope we adequately answered your two questions. Our time is coming to a close. So what I'd like to do is ask the six of you, and we'll start with Winkler and move around the table, to share with the audience sort of your parting piece of advice or recommendation, where we talk about sort of continuing to strengthen relationships and program integration between preparedness and immunization, based on your experience and also your own corrective action and continuous quality improvement, things that you yourself are going to do in the future to make that relationship even stronger and more impactful. What would be the one message that you would want to share with the audience, and maybe collectively we could generate 6 very strong recommendations? So we'll start with you.
Well, I think as it comes across on both grants that we need to collaborate, and I think we're doing that, and just continuing and having maybe some set meeting times once a quarter or something like that. I know my door is open and Andy's is open. We can go walk in on each other at any time, and I think that's the important thing, is knowing, build those relationships, continue them, and when issues come up on your grants or something else around the state, as you stay in communication with the EP folks, and you continue to coordinate out in the areas and do exercises and that kind of thing. So I think that's very helpful to keep those efforts going.
Thank you. I think the coordination with the locals is key. Hear that local voice, incorporate the locals into the planning process, and know that when the event happens, it's going to be a local event, maybe all over the state, but it's still a local event. So I would say local, local, local.
Great. Thank you. Chris?
And don't take the relationships for granted. Mm-hmm. And the planning, we do our planning in collaboration with our locals so that we not only have consistency, but we maximize the use of personnel, because we don't have a lot, and also input. And so we do a lot of our work as a team with the locals, and we need to continue that. And the same thing with the immunization program. As I said, it's taken a lot to build the relationships, and so don't take those relationships for granted. Continue to work with each other.
Barbara?
I think from my point of view, having my staff get actual training hands-on and actually doing something, whether it's an exercise or things like that, really emphasizes what we're about, and they can see it, because it's easy to be at the theoretical area without seeing what it actually takes and what all our partners are doing at the local level.
Inclusion, practice inclusion. Excellent. Joe?
Yeah, I think for us it's building tools that will work, both immunizations, both mass prophylaxis, trying to keep it as easy as possible for our local public health. We work great at the state level, and we want to make sure we can kind of push that idea down to our local level as well.
Great. Thank you. And Dan?
I would agree. I think it's continue to work with our partners both at the public and private level. I think that's all important. The collaboration can't be understated. I think we also have to keep in mind that we have to give credit when credit was due. I think because, we're not in this alone, and without our local and public and private partners, we wouldn't be able to get anything done. And I think we as program managers, whether it be on the immunization program level, working with ASTA, working with the Association of Immunization Managers, or I'm not sure if there's an equal association with public preparedness,
ASTA.
but also working with ASTA. I was going there, believe me. But I think when we see issues at the local level or at the state level, we have to bring them to our other colleagues to make sure that it's just not us alone in dealing with that issue. And bringing those issues to the fore, whether it's to the CDC or whatever. But also, again, like I said, when giving credit where credit is due, I want to take this opportunity to really thank our staff within our program, because there wasn't a lot of complaining. It was just the all hands on deck, as you mentioned before. Everybody stepped up and did what they had to do, and that's just not on our level. That's on the local level, at the private provider level. There may have been a grinding of teeth and a little nasties going on back and forth, but you expect that in the situation. But when it was all said and done, it wasn't anything personal. Everybody, I thought, worked together for the common good very well, and I was very proud to be involved in that.
Excellent points, and certainly as you all are strong managers and leaders, I could totally understand the loyalty and commitment of your programs on this and many other emergencies they handle on a day-to-day basis. So again, thank you all not only for your 6 closing thoughts and recommendations, but also for sharing with the viewing and listening audience your experiences and your advice going forward to how best to strengthen the program relationships and functionality of both immunization and preparedness. And I'm sure there are other sectors in state and local public health that can benefit from the wisdom that you shared with us all today. So thank you for that. Again, a special thanks to the University of Alabama and Emory, as well as CDC, for funding this initiative. So, Christy, I'll turn the program back over to you.
Yes, thank you for doing a wonderful job moderating. And again, to all of our panelists, thank you all for being here. A lot of you traveled from far distances, and we certainly appreciate your time today, as do the folks out there watching. So thank you all very much for being here. And